Hi, welcome to another episode of Orthopod. My name is Mo Bindari, the editor-in-chief of Ortho Evidence. And we're here with a trauma specialty update, and a particularly special one because we have a current event that's evolving. And we thought we would take the opportunity to provide some insight into that. I'm here with Dr. Brad Petrisor, who's a professor and orthopedic trauma surgeon at McMaster University. Welcome, Brad, and thanks for joining us on a trauma specialty update.
Yeah, thanks very much. Thanks for having me.
So why don't you fill in our members on the issue at large and what we're going to discuss today? Clearly, there's been a press release recently about a fairly substantial sports figure that I think relates directly to the issues of trauma.
Certainly does. As I'm sure most people know, Tiger Woods was involved in a significant injury. And I'm just going to read the statement that was put out on his public Twitter page,
Sure.
Just kind of as a disclaimer to know that anything that we talk about with respect to him is publicly known, and we're not privy to any other sort of information. But Dr. Anish Mahajan, who's the chief medical officer at UCLA Medical Center, says, Mr. Woods suffered significant orthopedic injuries to his right lower extremity that were treated during emergency surgery by orthopedic trauma specialists at Harbor UCLA Medical Center, which is a level 1 trauma center. He had comminuted open fractures affecting both the upper and lower portions of the tibia and fibula bones were stabilized by inserting a rod into the tibia. Additional injuries to the bones of the foot and ankle were stabilized with a combination of screws and pins. Trauma to the muscle and soft tissue of the leg required surgical release of the covering of the muscles to relieve pressure due to swelling. So that's
okay.
The official.
Okay, so in this trauma update, why don't we look at this as being the trending issue and obviously a topical one? Boy, it sure sounds like he had an open segmental tibia that was nailed and probably a fibular fixation to go with it, and probably prophylactic fasciotomies, or maybe not prophylactic, who knows? But would that be your assessment of if we were making the best informed assessment of what we're hearing from the lay description? Is that accurate?
Yeah, that's exactly what I would think. Segmental tibia treated with an intramedullary nail, and which would align up the main tibial bone. And then I'm not sure what other ankle and foot fractures there would have been, but typically plates and some screws would be used. And you can certainly have, distal fibula fractures that act more like ankle fractures that are associated with these segmental injuries. One thing we don't know is if there was any significant bone loss or anything like that. But when bones come out of the skin and when there's significant segmental injuries, it really speaks to a high energy trauma. And
well, this was a high impact. So he was a driver of a car and he was speeding, and we heard the term jaws of life getting him out. He was probably extricated, probably spent several hours, I'm guessing, in that situation. So clearly, you can imagine. So when you think about the principles now with respect to trauma management in this patient, there's going to be that, there's that early immediate management of that injury, which is, I presume in this case, is going to be the urgency of how we're going to deal with the soft tissues early on. And I wonder if we can break it down into categories and think about maybe evidence that could support what we might be doing in those situations. And I would say there would be the soft tissue management. There would be the appropriate bony management, and then there would be the post-operative, sequelae that would be dealing with the wound closure, I would imagine.
Well, I'd even break it down further into that pre-hospital, hospital level of care. I mean, he's going to need to be urgently taken to the hospital and splinted with appropriate basic limb support. But even in the emergency room, with open fractures, treatment starts right away. And we often talk to the residents about the mnemonic STAND, which is splinting the limb, checking tetanus status, antibiotics for sure, neurovascular assessment, sterile dressings, D, and then reassessment as necessary. And from an evidence-based point of view, antibiotics early and fast has a clear benefit with respect to post-operative problems. And the three main large issues with respect to bones coming out of the skin, as you well know, are infection, wound healing problems, and non-union. And the number one predictor of bone not healing is open fracture and the high energy that goes into it. So we can start our treatment right away in the emergency room with good quality evidence to suggest that antibiotics brings our risk of infection down. And depending on the number of studies that you read and look at, you're looking at a number needed to treat of anywhere from 13, 15, 17 patients. So for every one of those patients treated with an antibiotic, you can prevent an open fracture, an infection, if you take all comers.
Okay, so let's take a step back too. So what I would look at it is, and I go back actually to quote your paper, which would have been, you can remind me when, but I think we were talking about it was about 2003 that paper came out. There's a paper in the Journal of Orthopedic Trauma that was an observational study looking at, you can fill me in the numbers, but it was short, just shy of 200 patients, I thought, that you had reviewed. And you'd come up with 3 predictors of a secondary need for surgery after the treatment of a tibial fracture. And I wonder if we could break down what those factors were and then dig in deeper as to how we might look to mitigate the risk of some of those issues.
Yeah, those 3 key and subsequent studies also showed very similar things to what we showed in that original study, but it was open fractures were prognostic, a fractured gap, and a transverse fracture pattern. Those were some of the things that we identified. And all of those speak to the energy that goes into the injury because open fractures, transverse patterns, fracture gaps, all are higher energy types of injuries. So those were the 3 main things that we identified as being significant for reoperation.
Great. So what we'll do is we'll make sure that we provide a link to that paper for our members so they have an idea of what we identified. But let's take each one in turn. So infection, clearly, you can imagine the Tiger Woods injury, open fracture, they've done fasciotomies. Infection's a real risk early and you want to mitigate that risk. What are the fundamental infection prophylaxis measures we can take? So we've already talked at length already about the evidence for antibiotics. I don't think anyone would disagree with that. But what about sort of the early irrigation approaches? And we've talked about, what do you do with the wound? How do you debride the wound? How thorough it needs to be? And any evidence around that? And more importantly, what would be the recommended approach in 2021, so to speak?
Yeah, for sure. So debridement is vitally important because some of the skin tissue is dead and devitalized. Any dead and devitalized muscle tissue needs to come out. Obviously, any dirt or contaminants need to come out. And any dead or alone pieces of bone typically need to come out, although there's some evidence suggesting that you could wash some things, but we won't get into that just now. But the biggest thing to do is to wash the wound out and appropriate wound lavage. And that would bring into the concepts that we identified in the FLOW trial, which looked at fluid lavage of open fracture wounds. And it randomized with 40 sites around the world or more, I think, around 2,500.
Yeah, just over 2,500 patients, and we had just under 2,500 that were eligible for that for that trial. But you're right, it was a factorial design, Brad, if you recall, multinational, multi-center, and published in the New England Journal, I believe, in 2015. Yeah. And there were 2 arms. So maybe I'll share with you the 2 arms, and I'm curious if you can just give insight as to what would you be doing. So, for example, we looked at in one arm the type of irrigating solution. So we thought one at that time was Castile soap. So using a soap-based solution versus a saline solution was one arm. What was one of the factorial arms that we were randomizing against. And then they also received it under gravity flow, a low pressure irrigator, or a higher pressure irrigator, sort of the motorized battery operated irrigators across both. As it turned out, we found that there didn't appear to be any impact or any effect of the irrigating pressures on outcomes. And this is subsequent reoperations for infections. But we did find, in fact, that there was increased risk of reoperation with using soap. So clearly, that trial didn't help us with respect to using, soap as a potential benefit, but certainly gave us insight that maybe saline is all you need. I'm curious how that trial in general informs how you might be practicing in 2021.
Yeah, in 2021, we're using saline as our standard of care because of that trial. We're putting it in with, I still may use a low pressure lavage or gravity flow, just depending on how dirty things are. We know from that trial that there's no real difference with respect to outcomes, but sometimes just a little bit of pressure and a lavage gives you a little bit of sense of maybe just cleaning it up a little bit. But at the end of the day, there's no real difference with a big, large bore tube. The bottom line is to make sure that all of the contaminants or anything dirty is gone. So the principle where we can use saline or any pressure device that you want, or no pressure with a big, large bore tube, the principle is that wound is completely clean when you're done, period.
Right. So what's the, you always hear from seasoned traumatologists saying, you debride and you debride and debride. And when you think you're done, that's when you begin. Right. And you see the real seasoned expert, and often some of the experts also who deal with, let's say, total hip and total knee infection revision. That's the same principle they say. They say the biggest risk we have is we don't do enough. How do you ensure that you've done enough? And so in the case of a situation where you have, a segmental, sounds like it's a segmental open fracture, what would be the principle you'd be applying? Like, how would you know you've done enough?
Yeah, you expose and you basically expose everything, and you cut out anything that's dead and devitalized, and you go to where you can potentially see normal tissue, and then clean everything up. So a periosteum, dirty bone, muscle that's dead. So that's when you know you've done enough. When you see healthy tissue, the 4 C's of good muscle, capillary refill, color, consistency, etc.
Okay.
One thing that comes up when we're talking in rounds and things, well, people always talk about coming back for a second look, and those of us always say it's the second look is not because you haven't thought you've done because you've left some dirt. The second look is to see what muscle is surviving, to see what has been declaring itself. The first look is always, as you say, it's clean.
Okay, so let's say now we'll move on to the second phase. We believe that we now have appropriate antibiotic prophylaxis in place. We've done a thorough irrigation and debridement. We are now in the psychology of, okay, what are we going to do with this particular injury? You raised 2 points. Depending on how comfortable you are with your first step, you may change your approach. So what would be reasonable approaches to have managed the segmental open fracture before we get into what they actually did?
Well, there are 2 reasonable approaches. One, depending on the soft tissues that are there or not there, depending on if you can close the wound, depending on, it doesn't sound like there are any vascular injuries, but if there were, one approach could be a damage control type of approach, where you may decide to apply a temporary external fixation frame, which is bolts that go on the limb, so that you can come back to assess for further muscle damage and soft tissue problems. B, cover the soft tissue problems with a flap and then do definitive fixation. So that's one step. The other step is, if you have the comfort level and the expertise and the tools available to you, you can do definitive fixation right away, and then look after the soft tissue wounds. So there are a couple of different treatment algorithms depending on who's there, the comfort level of the people, depending on the injury and the soft tissues as well.
Okay, so let's go back now to your original paper, 2003. You tell us in that work that ensuring that we don't have a gap between the bone once we've done a fixation, because a gap between the bone, you can always imagine, can lead to a non-union and problems. And you also say that when fractures are transverse, they're more likely to be correlated probably with a gap and can create more problems because of surface area contact to get bone to heal. This is segmental fractures. An IM nail was done. And so why don't we stick with the IM nailing of a segmental fracture? What would be the concerns you'd have with IM nailing of a segmental fracture as it relates to ensuring a good outcome?
Yeah, IM nailing from a technical point of view is got some issues with segmental fractures, because it usually means you're dealing with short proximal segments. And when you're dealing with short proximal tibial segments and a distal segment that you have to align, it means that you've got to do a couple of tricks to get that nail in and get the fracture aligned in as good a position as you can, because it can be difficult to deal with short proximal segments. So you need to know some tricks. You need to get a completely accurate start point. Some people talk about a little lateral. Others argue that it needs to be completely lateral. You need to have hug the anterior cortex as you come down. People talk about semi-extended nailing, where you can have a little bit of a bigger incision proximally so you can align the fractures.
But the point of semi-extended nailing really was to deal with that proximal flex fragment, correct? So you're trying to bring the distal fragment up to that flex fragment. Another way I imagine you could deal with it, Brad, I presume you could, is just using some sort of Polar screws, blocking screws.
Yeah, Polar screws, blocking screws.
Okay.
And then the other one is if it's open, if both segments are open, you can just put a little unicortical plate on the proximal segment and put the nail in and then remove the plate or not thereafter. So there are definitely some tricks to do with the proximal segment. And the same goes for how distal it is. If it's right in the shaft, then that shaft will typically line up. But if it's more distal and closer to the ankle, then you can have varus or valgus malformations down there too. So sometimes you need to do blocking screws down there and stuff like that, or the palisade technique, as some people call it. So definitely there are some tricks, but intramedullary nailing, when done like that, can have less soft tissue stripping than plating, traditional plating, and it can allow for differences with respect to postoperative status and weight bearing and things.
Okay, so let's address that other issue. So let's say we've got the nail in place and we're trying now to avoid a gap. What are tips? And, and the gap can either be proximal or distal. In a segmental fracture, the challenge is, it could be either way. And if this is truly one of the more difficult, challenging ones, it's just going to be two, almost like a central sausage in the middle, where you've got to deal with two potential gaps to manage. I'll just raise one point. Dr. Ternetta, Paul Ternetta, I think is known to many in the trauma field, spoke earlier, and I always remember him talking about do your distal locking screw first, get the distal segment locked, and then back tap to try to take that fracture segment and close it down before you did your proximal locking. Are there other techniques that could be used to ensure or to minimize the risk of a gap, assuming we have a transverse fracture? Because that's really where that problem becomes, because a small gap becomes a full 360 circumferential gap.
Yeah, 100%. So we're making a couple assumptions here that we should say. We're assuming that there's no bone loss and it's a transverse fracture.
Correct.
So in that case, locking distally, back tapping is one way. These new nails, well, new, I say new in the past 10, 15 years, you can actually put your proximal screw in dynamic position, and then you can put a compression screw down the top, and so you can compress and draw the nail back in.
Sure.
That's one way. The other way is you can use things like compression distractors and compression device, articulating compression devices if you want. But usually the way would be to do what Dr. Ternetta says, or to put the compression screw in and drop it back. That'll generally squeeze things down. Now, to your point though, in open fractures, sometimes we're actually missing bone. Now, if we're missing bone and we compress and shorten, then the leg will be short. So in that instance, there are two philosophies. One, nail it out to length with a known gap and know that we might need to go back in and fill the gap, or shorten the leg on purpose, bring the gap closed, and then lengthen the leg back over the nail. Now, we don't know which one is better, and some people have their druthers, so to speak.
Yeah, right.
Someone who puts the leg where it should be and then goes back to fill the gap. Although with some large defects, we have done it the other way around, and both can work.
Well, let me say this. So we haven't talked about, and I wouldn't say it's the elephant in the room, but the elephant in the room for a tibial is, do you ream or don't you ream, and how much do you ream, and what's the impact? And the segmental fracture, particularly important because you've got that central free-floating fragment, right? So the SPRINT trial, as you recall, was a very large trial. I mean, we had, I think, just under 1,300 patients, and it was probably one of the first larger multi-center trials published in the Journal of Bone and Joint Surgery 2008, and we'll make sure we also provide this to the membership as one of our ACE reports. But that study did suggest, in fact, that whether you ream or you don't ream didn't have a huge impact. Now, the caveat is that the non-reamed nail diameter and the ream nail diameters are very, very close. So I think what was happening is probably, one would argue, that a limited degree of reaming, for the most part, probably would make the most sense. In an open fracture, one might have argued biologically that doing a non-ream nail might be more preserving to the soft tissues, but it didn't pan out that way. The trial wasn't powered for it, although it trended in favor of the unreamed nail in the open fracture. In the segmental fracture, though, that's yet another complication in that area. I wonder what you would look at the SPRINT trial, and you would look at overall sort of the findings that where overall it said, listen, for closed fracture, ream nails tended to do better than non-ream nails. But in the open fractures, there was no difference, but it trended towards the unreamed nail. What would you be doing here?
Yeah, that's a hard one. The unreamed nail means you got to drop down your nail size, and in a segmental thing, it really makes it tough because your tract has to be perfect. And so I'll be honest, I would ream a little bit with the segmental component, because if I needed to use any blocking screws or anything like that, you kind of get your path a little bit easier. You can get your you can finesse the techniques a little bit better with a little bit of play in there. And given the fact that it wasn't from an evidence point of view completely, I don't think it was, as you just said, completely fully powered to show a significant difference.
Correct.
I think with the segmental component, it would allow us to just, I would rather err on an accurate and good reduction with cortical continuity, and just potentially ream just a touch, even though I know. Now what you could do, and again, depending on where the open fracture was, you can do your proximal bit there. You don't have to go crazy on the shaft too. You can, my main concern is that short proximal segment, getting that right, and then we can tweak the bottom part a little bit. So
absolutely. Yeah, I mean, yeah, and if you look at kind of what I think we settled on back then when we were discussing, it was at a canal filling nail. So you know the historic early unreamed small diameter nails that left a lot of instability was a big problem. And also remember, the smaller diameter nails had very small distal locking screws that broke.
They would drop to 4 millimeters.
That's right. So you want to get to a big enough nail that you can get a pretty stable, distal and proximal locking screw. Well, primarily the distal locking screws in place to allow you to have a stable structure that you can add upon. And then it sounds like they did some fixation of an ankle, or at least in that area, because they mentioned fibula by name there. So you're assuming there's a fibular plate at a minimum in this area. Any risks with plating the fibula, sort of the fibular fixation actually leading to distraction on the tibia side as well? I mean, there's all these little issues you have to think about when you're fixing it in terms of order. I imagine that you would agree that the order would be fix the tibia and then manage the fibula, or would you assuming there's no bone loss, right? If there's bone loss, you might want to use the fibula for length, I presume.
Yeah, so it depends on the fibula, and it depends on the fractures and all that sort of stuff. So if we're talking about a fibula similar level to the tibia, above the level of the syndesmosis, then I'll do the tibia first, and I would tend not to worry about the fibula. For me personally, if the fibula behaves more like an ankle fracture down distally, and I'm worried that there may be some rotational stuff, as some of the JOT trials have suggested, may benefit from a plate, but not if it's behaving more as a shaft. Now, interestingly, our colleagues, Atul, he'll put in at the Sanchetti Hospital,
yes,
who does a lot of trauma. He'll put a flexible rod up the fibula to help align, and then put the nail down the tibia. So sure. He has a different philosophy, and it seems to work well for them. But and for him, but me, I go with the tibia first, and okay. Then I usually don't do anything to the fibula unless it behaves like an ankle fracture.
Okay, so in this case, it looks like a nail was done, some fibular fixation was done, and it looks like, it's hard to know, they don't state compartment syndrome as a title. I suspect it was prophylactic fasciotomies, because I believe if there was a compartment syndrome, it would have been a significantly important enough messaging to let people know. But it looks like there were some fasciotomies conducted at the same time. What's going to be assuming that's the case, what's going to be the post-op course now for this particular fracture? And realistically, what's the prognosis for Tiger Woods getting back and moving on that limb?
Well, I think that seems to be the big question. He'll get back and moving on the limb. The question will be whether he gets to the level that he's been at.
Sure.
And unfortunately, my discussion with patients who have these bad injuries are, your leg is not going to be the same again. I do go through some things. So there's big risks here for not healing of the bone, as we've talked about, big risk for infection, and other wound healing problems. And what we don't know is how big the incision was or needed, or how the soft tissues are playing with respect to the compartment release. Will you need secondary closure with skin grafting, or will they be able to close it primarily in a couple of days, etc.? I'm not sure what those, and we don't know if there's any segmental bone loss. But they're pretty serious injuries, and can result in significant changes with respect to stiffness in ankles and knees and things like that. And I have these discussions with our patients all the time, but I always say to them, and if you prove me wrong and you're back into it, and then that's a good thing. So
Yeah, there's a motivation factor, and certainly he's someone who's been through multiple back surgeries. He's been through multiple
100%.
rehabilitation issues, and so I think there's a lot of opportunity to imagine that he's going to work pretty hard at getting back. But let's go back to your 2003 paper. Basically, he has some risk factors for need for reoperation and within 12 months. So he's not out of the woods, so to speak, right now at all. In fact, with an open fracture and a complex fracture that may in fact have some transverse fracture components. It is not an insignificant risk that he may require reoperation within the next year. And I would be not betting against that rather than, assuming that things are going to go super, super fast. If they go well and he continues to heal, the SPRINT data, some of the secondary analyses of SPRINT, and I think you know this as well, Brad, the curves to return to function, even at 12 months, there was still quite a bit of knee pain. There was still quite a bit of functional limitation. And the recovery hadn't plateaued at even 12 months out. So you've got to get the fracture to heal. And then you've got to spend another 12 months in rehab, and we'll say, this is for the average patient that's coming in and getting rehab. So there is definitely a long road back towards function, and then at the level of elite function, that's a different story altogether.
Yeah, 100% agree.
So anything else that comes to mind regarding this particular case? I mean, outside of what we've already talked about, is there any role for biologics? Anything else that you think that right now that we might consider applying? We're talking about trying to get a high performance athlete back to performing.
Well, I mean, your group did that trial with bone stimulation, suggesting that there may not be a significant benefit, I think, correct?
I think for fresh fractures, that were otherwise closed for the most part, there doesn't seem to be a huge impact that we could identify. But if you look at what happens in the delayed fracture area and the non-union, boy, there's a real opportunity there, and you don't know, right? So we don't know, so it's a matter of watching.
And that's one of the things that I would categorize this as being a significant fracture at risk. And if it does start to go to that delayed union situation, then potentially some form of bone stimulation may be beneficial. And if there's any fracture gaps, then obviously bone grafting and biologics that go along with that maybe provide some potential benefit, although nothing has been shown, I don't believe, to be superior to iliac crest autogenous bone grafting, but there's certainly augments that you can put in there. And there's cost aside, there's minimal downsides to them. And so when fractures are at risk, you tend to start to put a few more of these things on the table because there is quite significant disability to fractures that don't heal.
And I'll leave you with the one last point before we close this out, which is pain management following a bad injury like this, is really important. Knowing that Tiger Woods has had a pretty public history of having issues with opioid addiction, what would be some of the challenges in maintaining pain control for him as they think about, getting him to be, getting back to function, but also managing the pain that's going to be associated with that early perioperative period?
Well, the challenges are definitely issues around narcotics. And so the bylines these days are multimodal pain management. The problem is there has been conflicting evidence, and I know that you've got evidence on ortho evidence about anti-inflammatories and fractures. And there's been swings in terms of anti-inflammatories can inhibit fracture healing versus no, they don't do anything. And so there's a little bit of a back and forth. And the problem is when you have a fracture at risk, Do you supplement with anti-inflammatories, et cetera? And where does the role of CBD come into play? Is there any role for cannabinoids, non-THC, non-psychoactive? So I think, and in the immediate, anyway, so there's definitely a need for multimodal therapy, and each arm of the multimodal therapy can mitigate the risks of having only one high. So you can have an anti-inflammatory with a little bit of narcotic, maybe a little bit of something else to help titrate the doses.
Yeah, so I think the real issue here is, there's multiple issues, right? Which is in the goal now is to get these fractures to heal and get the soft tissues to heal. That's going to be the first phase. Coincidentally, also working on getting, back to function, but getting back to function means managing pain, right? So all of those issues are going to be, I think, the issues that we're going to be hearing about, and are the issues that every single patient who has these complex injuries has to deal with. We're just getting more light to them now because there's someone that seems to have a public interest in it. But I think very timely for a trauma update to have you with us today and be able to spend some time talking about this particular issue. So thank you again, Brad, for sharing some insights on a particularly complex issue, but one that I think most every orthopedic trainee and many of our orthopedic surgical colleagues have to deal with on a monthly, if not weekly basis in some of the busy trauma centers they work at.